My name is Richard Isaacson, Associate Professor of Neurology and Director of the Alzheimer's Prevention Clinic at Weill Cornell Medicine, New York Presbyterian Hospital in New York City. Welcome to this program on Alzheimer's disease diagnosis, prevention, and treatment. Before I begin, I would like to note that this program will include discussion of off-label uses of therapies approved by the FDA for use in the USA. In addition, this program will include discussion of investigational agents not yet approved by the FDA. The goals of this program are to discuss the importance of early diagnosis of Alzheimer's disease, describe optimal preventative approaches in Alzheimer's disease, and review new and emerging therapies in Alzheimer's disease. Before we begin, please take a moment to test your knowledge on this topic by answering a few questions that will be presented in just one moment. You will have another chance to answer these questions at the end of the activity to see what you've learned. Let's start with an overview of Alzheimer's disease. Over the last several years, new diagnostic criteria have been released that really underscore the new science that shows that Alzheimer's disease starts in the brain at least 20 and up to 30 years before the first symptoms of memory loss. There are now several new stages of Alzheimer's based on the new 2011 new criteria. So many of us understand that people can be normal, but there's a transition between normal and Alzheimer's disease that occurs in several stages. So the first stage is called preclinical Alzheimer's disease. Preclinical Alzheimer's disease, or stage 1 AD, actually means that the disease has started in the brain, but there are no symptoms yet. When that person starts to develop symptoms slowly over time, and the symptoms are mild, that person may have mild cognitive impairment due to Alzheimer's disease or stage 2 Alzheimer's disease. The stage 3 of Alzheimer's disease that we now call as Alzheimer's disease dementia is the stage that most of us have talked about Alzheimer's disease in the past. Many of us include the use of mild Alzheimer's disease, moderate Alzheimer's disease, and severe Alzheimer's disease in our understanding of the disease. However, that is now synonymous with stage 3 Alzheimer's disease dementia. So as a person progresses from normal to stage 1 to stage 2 and stage 3, this is where the new science is going, and this is where different preventative as well as treatment strategies will approach Alzheimer's disease. When it comes to Alzheimer's disease diagnosis, early diagnosis is essential. The earlier the person is diagnosed, the earlier the treatments can begin. And what we find is that the earlier the treatment can begin, the better the patient will do. When it comes to the stages of Alzheimer's disease, the goal of some of the new and emerging therapies for Alzheimer's prevention would be to start treatments in either the preclinical Alzheimer's phase or mild cognitive impairment due to Alzheimer's phase. When it comes to doing an assessment for a patient with Alzheimer's disease, you have to do a variety of things. As a neurologist, we do a very comprehensive clinical history. We learn about the patient's symptoms, the temporal course of the symptoms, the other non-cognitive symptoms, aspects like mood, changes in sleep. We also talk about other specific cognitive symptoms, not just short-term memory loss, but language, visuospatial difficulties, problems with praxis, behavioral issues, as well as executive function. We also do a history and try to figure out, does the person's cognitive impairment interfere with the activities of daily living, or can they still take care of themselves? The classic definition of MCI, or mild cognitive impairment, is when a person has some mild memory loss, but they can still function in society and do all of their activities of daily living. When that person can no longer take care of themselves, that person has progressed from MCI due to Alzheimer's into the next phase, or stage 3, Alzheimer's disease dementia. It's important when working up a patient and talking to the patient to screen for depression, do a physical examination for Parkinsonism, and also look for other sources of dementias, evaluate for sleep apnea, and also look for symptoms or signs of vascular disease. It's also essential to do a very detailed family history as well as social history. As most of us know, there is a genetic component to Alzheimer's disease, and while age is the #1 risk factor for Alzheimer's, family history is a close second behind that. It's also important to note social history and the medications that a person can be on. There's a variety of medications that may have side effects that may actually mask or confuse the case where a person may present with cognitive impairments, but those cognitive impairments may be actually due to a medication side effect. After the history is performed and a physical exam is completed, the clinician usually relies on a variety of cognitive tests Now, these cognitive tests can vary depending on how much time you have with the patient. For example, if it's difficult to spend any time with the patient doing cognitive testing, there is a scale called the 88 developed by Jim Galvin and colleagues at Washington University, where even in the waiting room, if you have no time at all, you can actually do a quick 8-question questionnaire to try to determine whether the person is having memory loss that may be consistent with Alzheimer's disease. If the practitioner at least has a few minutes, for example, 7 to 10 minutes is the usual time it takes for a reasonable screening test called the Mini Mental Status Exam, or the MMSE. That is one of the more common tests that is used. However, a newer test called the MoCA, or the Montreal Neurocognitive Assessment, is another scale, another 30-point scale, that has been shown that actually may be higher in sensitivity to cognitive decline in longitudinal monitoring, and an optimal cutoff is below the number of 22 for MCI and below 17 for Alzheimer's disease. And at these cutoffs, the MoCA showed statistically significant values compared to the Mini Mental Status Exam in terms of positive predictive value. When it comes to laboratory testing, and this is in the case of all patients, we should always be mindful that we should work up for medical causes of cognitive impairment and memory loss. According to the American Academy of Neurology guidelines, there are some standard tests that are suggested, checking for B12, hypothyroidism, doing routine blood work, a CBC, liver function, other variety of screening tests may or may not be helpful depending on the selected case. Genetic testing for Alzheimer's disease patients is actually controversial. There's really no standard reason why most people would perform a genetic test for Alzheimer's disease in order to come to a diagnosis, unless that person, there was a suspicion of early onset Alzheimer's disease. Early onset Alzheimer's disease makes up around 6% of all cases, where there are one of 3 mutations, actually amyloid precursor protein, presenilin 1 or presenilin 2. It can cause onset of cognitive dysfunction in people usually earlier than 60 years old. Y'all have probably heard about the gene called ApoE4. 1 copy of E4 increases your risk somewhat, and 2 copies of ApoE4 increase your risk of Alzheimer's disease by a little bit more. So some people say that maybe having this gene increases the diagnostic yield of Alzheimer's. I'm not sure that I agree with that. In our practice, we use ApoE4 status not to help with a diagnosis, but actually to help understand the disease pathology a little bit better and actually tailor some treatments. There's another gene that's quite interesting called TOM40, and TOM40 is actually right next to ApoE4, and ongoing research will help clarify this. Another gene that was discovered in the last several years is SORL1, also associated with late onset Alzheimer's disease. When it comes to laboratory testing, spinal fluid testing is helpful in cases where we're not sure what the diagnosis could be, and what we use is a signature of testing, meaning A-beta 42, as well as total and phosphorylated tau in the spinal fluid. And these can be sent off, and if each of these findings are in a specific ratio, then it may or may not be consistent with Alzheimer's disease. When it comes to neuroimaging, there's really been exciting advances over the last several years, including now 3 FDA-approved imaging agents for looking at the amyloid plaque or amyloid protein buildup in the brain. Most people, and based on the American Academy of Neurology guidelines, most practitioners usually yield toward either offering a CAT scan or an MRI to rule out any structural, vascular, or other potential causes of memory loss in a patient that presents. The standard in my practice is to use an MRI, and not just use a regular MRI, but we order it with thin cuts through the hippocampus, or thin coronal cuts. The reason why we do this is because the best way to look at an MRI from our perspective is looking at the volumetric approach, meaning is there atrophy of not just the whole brain, but atrophy or shrinkage of the hippocampus. So that's one way that we can do that. When it comes to additional tests, FDG PET scanning, a PET scan can look for metabolic signatures of, for example, temporal and parietal hypometabolism. But even more sensitive and specific would be a PET scan where we use an amyloid labeling agent. The first FDA-approved amyloid labeling agent was called florbetapir, and that was approved in 2012. And this basically estimates the amount of beta amyloid plaque density in patients with cognitive impairment. Flutemetamol was released in 2013, and florbetaben was released in 2014. All of these three are commercially available, and the unfortunate part is they're not just yet covered by insurance. There's another type of scan called a tau scan that is recently becoming available in terms of research purposes, and what we think is that tau scans may actually become part of either the diagnostic, prognostic, or progression indicators for the disease. Tau scans are now often being used in a variety of clinical trials that are ongoing. Several years ago, it really wasn't even able, as practitioners, to talk about Alzheimer's disease and prevention in the same sentence. Now we can. We started the first Alzheimer's disease prevention clinic in the country, and now there are several that have developed all over the United States, and several more that are expected throughout the world. What we try to do in these clinics are to see a patient, assess and address modifiable risk factors, gain information on cognitive function, and then track that person's cognitive function over time. The goal of an Alzheimer's prevention clinic approach is to do a comprehensive history, get as much information about the person as possible, understand their risk factors, give them a personalized plan, and then follow both their risk factors in terms of nutritional, lipid, metabolic, and inflammatory biomarkers or lab tests, and then also follow their cognition over time. The goal is to try to intervene in a very personalized or clinically precise way. In doing so, we try to focus on evidence-based pharmacologic and non-pharmacological management strategies. So when a person comes in for the clinical purpose of Alzheimer's prevention, what exactly do we do? Well, the first step is to try to figure out what are the non-modifiable versus modifiable risk factors. And we spend most of our time discussing and trying to put together a plan based on the best evidence for modifiable risk factors. When it comes to non-modifiable risk factors, like we talked about before, age and family history are among the two most both non-modifiable and causative aspects of Alzheimer's disease. But also there are several past medical problems, level of education, past head trauma, or loss of smell. These are all things that may increase a risk of a person's developing Alzheimer's. When it comes to modifiable risk factors, there are several. We'll talk more about this in a moment. Cardiovascular risk factor metrics such as high blood pressure, even certain medicines may be targeted to not just improve blood pressure control, but potentially reduce Alzheimer's risk, cholesterol management, and of course diabetes. People with diabetes have double the likelihood of developing Alzheimer's disease. So what we try to do in a clinic approach, or what one thing you can try to approach in a patient who is at risk for Alzheimer's disease, is to talk to them, identify their modifiable risk factors, and try to put them on a risk-reducing plan. One of the strategies that we use, in addition to talking to the patient, ordering the labs, is also education. And what we have is a educational platform that's basically available to anyone for free online, where patients can actually take a course about Alzheimer's disease risk reduction. And that website is called Alzheimer's Universe, or alzu.org. When it comes to prevention trials, aside from just doing clinical management of Alzheimer's disease, there are now a variety of Alzheimer's disease prevention trials that are ongoing. Some of these are focused on early onset cases, and others are focused on late onset cases. One of these trials is called the DIAN study, or the Dominantly Inherited Alzheimer's Network Trial. It will enroll over 200 patients in 5 years with a variety of different treatments, one called gantenerumab and the other called solanezumab. There's another study called the Autosomal Dominant Alzheimer's Disease Treatment Trial that will enroll 300 patients over 5 years, and this is focused in the country of Colombia using a monoclonal antibody against amyloid called crenezumab. These are patients targeted for patients with early onset Alzheimer's disease, so again, a very small subset of the population. Alzheimer's prevention trials that are ongoing for late-onset Alzheimer's disease are ongoing now, and several more are coming underway soon. One of the most well-known studies is called the A4 study, or the Anti-Amyloid Treatment in Asymptomatic Alzheimer's Study. In this study, people with normal memory or some mild, very mild subjective memory loss between the ages of 65 and 85 can actually enroll in a study where if they pass an initial cognitive screening and then they have a amyloid PET scan that is positive, they can actually be randomized to either receiving placebo or something called solanezumab, which is another monoclonal antibody against amyloid beta. We'll talk about this drug a little bit more later. There's another study that recently closed called the Tomorrow study, and in this study, patients were looked at by an approach where I think we'll be learning much more about in the future called pharmacogenomics in Alzheimer's disease, where patients were looked at for the ApoE4 gene as well as their TOM40 gene. Many thousands of patients were recruited, both normals and mild cognitive impairment, very, very mild memory loss. And the goal of this study is to try to determine the effect of the insulin sensitizing agent pioglitazone on the outcome or the prevention or delay of Alzheimer's disease. Another study called the API, or the Alzheimer's Prevention Initiative ApoE4 treatment trial, is also looking at cognitively normal individuals with 2 copies of the ApoE4 gene. They'll actually be looking at not just an amyloid immunotherapy arm, but also a beta secretase inhibitor arm. When it comes to multimodal interventions, right now we don't have the magic pill, the magic drug, the magic infusion that's going to prevent or cure Alzheimer's disease. However, based on the best available evidence that's been around now for several years, the evidence shows that 1 out of every 3 cases of Alzheimer's disease may be preventable. What the prevailing evidence shows that if we can provide a comprehensive approach that includes nutrition, physical exercise, specific evidence-based cognitive activities, other cognitively engaging activities like music interventions, regular follow-up with the primary care doctor to assess and address cardiovascular risk factors, reducing stress, increasing social interaction, maintaining sleep hygiene, and making sure the patient is educated about their risks. I believe, and I think the field is now coming around to think, that we can make a big dent in the epidemic that is Alzheimer's. When it comes to nutrition in Alzheimer's disease, it seems like almost every week or two there's a new major study coming out that supports the role of nutrition in the brain. When it comes to you are what you eat, it's the same, you are what you eat when it comes to brain health. Many people say that, well, if what's good for the heart is good for the brain. Eat a heart-healthy diet, that's a brain-healthy diet. Well, I think that's close, but I think what we're learning is that there are some subtleties, and recent nutritional intervention trials have actually shown effect sizes that are as large or close to those seen with some available FDA-approved drugs on the market. When it comes to nutritional interventions, we want to try to divvy it up between 2 separate categories. Number 1 is dietary patterns. The dietary patterns that have been most studied include, again, the Mediterranean-style diet, the low saturated fat and low high glycemic index diet, the ketogenic diet, caloric restriction, the DASH diet, the MIND diet, and also pretty recently a study called the FINGER study, which we'll talk about later. When it comes to single or multi-nutrients, we know that instead of eating a very specific dietary type, we can have very specific components. So there's also been studies looking at B vitamins, for example, folic acid, B6, and B12 in combination, vitamin D, omega-3 fatty acids, either coming from fish itself or from supplements, curcumin or turmeric root. One of the exciting areas in Alzheimer's disease research is trying to use an alternative fuel source for the brain. The brain usually uses glucose or sugar as its primary fuel source. However, the backup fuel is ketone bodies. And in one study in mild cognitive impairment by Dr. Robert Krikorian and colleagues, they actually compared a high carbohydrate versus a very low carbohydrate ketogenic diet in patients with MCI. After 6 weeks, just 6 weeks, patients were able to improve their verbal memory performance, reduce their weight, reduce waist circumference, reduce fasting glucose, and also reduce fasting insulin. Now, this is one small study, but these results were significant, and it really sets the stage for additional research in the future. There's also a phase 3 ongoing clinical trial using a medium chain triglyceride for mild to moderate Alzheimer's disease. And this study should be completed in the next year or so. And again, instead of changing a dietary pattern to induce ketosis, this is a strategy to try to use a drug approach where you drink a medium chain triglyceride to try to improve cognitive function in a person with mild to moderate Alzheimer's disease. And results of this should be available in a few years. When it comes to Alzheimer's disease treatment, if we want to focus on some of the single or multi-nutrients that have received a lot of attention, one of these is the omega-3s. Now, the omega-3s is an interesting story. When omega-3s in the past have been studied for Alzheimer's disease treatment, there's actually been no change in mild to moderate Alzheimer's disease. When it comes to Alzheimer's disease prevention, however, things are a little bit different. There was a study published in 2010 called the MIDAS trial, where they looked at 900 milligrams of DHA, and this is an algae-based DHA, so not from fish, but from algae. And in that study, patients with age-related cognitive decline did show benefit. Most recently, presented at the recent clinical trial on Alzheimer's disease meeting in Barcelona, the MAPT trial was presented. And the MAPT trial is a multi-year prevention study ongoing in Europe that has actually shown that either using the combination of a multimodal lifestyle intervention like dietary changes, exercise, as well as 800 milligrams of DHA and 200 milligrams of EPA, another omega-3 fatty acid, the addition of the omega-3 fatty acids in that case showed significant benefits. And these studies will be ongoing. The other key here is that, as we've talked about, the pharmacogenomic and nutrigenomic concepts that we're learning about in Alzheimer's disease continue to evolve. So in this MAPT trial, actually showed that patients who are ApoE4 positive tended to respond better to the DHA and EPA or omega-3 fatty acid treatment via a supplement. The major rule of thumb here is that when we look at the evidence, it's always better to get omega-3 fatty acids from eating fish on a regular basis, at least once, and in my practice I suggest at least twice per week. A recent study by Dr. Martha Claire Morris and colleagues was published in JAMA, actually in February of 2016, that showed that eating fish multiple times a week not only reduced your risk of Alzheimer's disease, but also in Alzheimer's plaques in the brain. Another very exciting area of intervention, mostly for prevention, is the evidence on B vitamins and B complex vitamins. Studies by David Smith and colleagues have actually shown that in patients who have an elevated homocysteine level, or a marker in the blood, that are treated with B vitamins, so 0.8 milligrams of folic acid, a half a milligram of B12, and 20 milligrams of B6 per day. Those patients actually had improved memory scores on the mini mental status exam, and category fluency and episodic memory, and also significantly decreased the rate of atrophy. It was actually 53% lower in the active treatment group. However, in patients that don't have elevated homocysteine, these B complex vitamins may not be effective. This also underscores research that was done by the Alzheimer's Disease Cooperative Study several years ago, back in 2008, that showed that B vitamin treatment in patients with mild to moderate Alzheimer's disease actually had no effect at all. There's also even research out there from several years ago that showed that the effects of cholinesterase inhibitors, so the FDA-approved drugs for mild, moderate, and severe Alzheimer's disease, there is now several available, that just using the addition of a small dose of folic acid in addition to the cholinesterase inhibitor in a randomized study, again a small study, actually improve the likelihood that someone would respond to the cholinesterase inhibitor. So again, intriguing research, relatively low risk, so these therapies may turn out to be a sensible option for both Alzheimer's prevention as well as, in this case, Alzheimer's treatment. Another exciting area of research is in the area of flavonoids. There's really now strong evidence to support the regular intake of blueberries and strawberries. In one study, the Nurses' Health Study, showed that regular intake of these berries, at least twice a week, a half a cup, delayed cognitive decline for over 2 years. So in my clinical practice, I recommend eating either blueberries or strawberries, a half a cup, at least 2, even 3 to 4 times a week. Also, now several studies have investigated the utility of dark cocoa powder in cognition, and in one study, and actually published in the Journal of Hypertension, showed that heart attack patients that had regular intake of dark cocoa powder improved memory, blood pressure, and insulin resistance. And we recently did a review on from the literature when it comes to coffee and the brain. And what has been shown is that overall we believe, based on the best available evidence, that drinking coffee, several cups in the morning, is actually probably beneficial for the brain. There's been several prospective studies, European studies that have been done, and in one study the most benefit was with 3 cups a day. Now 3 cups a day is not a venti, dolce, mocha latte from your favorite coffee place, but we're actually talking now about the coffee itself. And 3 cups is the European way of 375 milliliters, or about 12 ounces of coffee. In one study showed the most benefit. When it comes to cognitive interventions, there's a variety of cognitively demanding and cognitively stimulating activities that I recommend in my practice. However, the jury is still out about several of these activities. When it comes to something common that you've all heard about called Sudoku, you can do all the Sudoku you want, but you're just going to get better at Sudoku. The key thing here is that you should try to engage your patients in a cognitive activity that has a spillover effect. So learning a new musical instrument, new hobbies, new languages. When it comes to symptomatic therapies, so transitioning now to the treatment of Alzheimer's disease, most of us understand that there are now several FDA-approved treatments that are available. One category is acetylcholinesterase inhibitors, and this is donepezil, rivastigmine, and galantamine. And then there's an NMDA antagonist medication that's FDA approved for moderate to severe Alzheimer's disease in combination with an acetylcholinesterase inhibitor. These drugs provide some modest benefit and are a major part of my therapeutic armamentarium against Alzheimer's disease. However, using these drugs alone and not also focusing on the lifestyle interventions and the other non-pharmacological approaches, I believe are doing our patients a disservice. Some new drugs on the horizon include anti-tau antibodies. One drug is currently in phase 3 studies. The phase 2 studies didn't show much benefit in patients with mild Alzheimer's disease, but it was effective in patients with moderate Alzheimer's disease at 24 weeks. However, at 50 weeks, there was benefit in both groups. So, of course, we need to keep studying, keep doing robust clinical trials, bigger numbers. Phase 3 studies will help figure out whether an anti-tau antibody may be part of the therapeutic path in Alzheimer's disease in the future. The anti-hyperglycemic route, the study called the SNIF study, is looking at intranasal insulin. And in one study published several years ago by Suzanne Kraft and colleagues, showed improved delayed memory with a 20 international unit dose and preserved caregiver functional ability at the 20 and 40 international unit doses. This is a study that's ongoing now, and the delivery device has been updated, so we're eagerly anticipating these study results. When it comes to the anti-amyloid beta approach, there are now a variety of very exciting studies that are ongoing. One of the more recent studies that are beginning clinical phase 3 trials now are aducanumab. Aducanumab is now in 2 phase 3 studies called Engage and Emerge, and this was based on some phase 2 data that looked promising. While the phase 2 data did not show significance on slowing disease progression on 2 somewhat rudimentary cognitive measures and compared to how we need to do the phase 3 studies. However, it did show a significant effect on amyloid plaques. There's also the drug solanezumab. Now, solanezumab is the same anti-amyloid drug that's being used in the A4 Alzheimer's prevention study. It's also being looked at in phase 3 studies. Solanezumab has been studied in several studies called Expedition 1 and Expedition 2 for the mild to moderate Alzheimer's disease groups. However, in those studies, there was no significant differences for the mild mini-mental status exam score or the CDR, or Clinical Dementia Rating Scale, sum of boxes after 108 weeks. However, there were significant differences between the delayed start group and the initial treatment in other measures at 108 weeks. As such, we're now finding that the earlier that we can intervene, the better these treatments may work. And as such, the Expedition 3 study was started, which is another phase 3 study looking at solanezumab. Another drug called gantenerumab, called the Scarlet Road trial, is ongoing, and initial data showed significant reduction in cerebral spinal fluid tau at week 104, and a trend for a change in amyloid PET, but no change in cerebral spinal fluid amyloid beta. Crenuzumab is also in a phase 3 study, again, another anti-amyloid beta drug, and we are looking forward to these results. The final anti-amyloid beta drug that I want to cover is called bapineuzumab. Now, bapineuzumab did fail in terms of not meeting its clinical endpoints, but bapineuzumab was an exciting pathway for our field because it set the stage for understanding in which types of patients and in which stages these drugs may or may not work. So while we have been hit with failure after failure, I can say that we have at least laid the groundwork for future success in our understanding of how to optimally treat Alzheimer's disease. Another anti-amyloid strategy would be the BACE inhibitors, and verubestat is in multiple trials now. The Alzheimer's disease treatment trial for mild to moderate AD trial has recently closed, and the mild cognitive impairment due to Alzheimer's disease trial is currently ongoing. So to conclude, there are several components to both an initial assessment as well as diagnosis of Alzheimer's disease, and the multimodal approach towards attacking Alzheimer's disease in terms of an evidence-based yet safe way is really where the field is at today. Preventative strategies are exciting. We don't, again, have a magic anything to prevent or cure Alzheimer's disease, but we've really laid the groundwork and are really making tremendous strides. Several therapies are in clinical trials to reduce amyloid plaques in mild Alzheimer's disease, and others are hopefully going to demonstrate not only just a clinical benefit, but hopefully a neuroprotective effect in years to come. Thank you for participating in this activity. You may now revisit those questions presented at the beginning of the activity to see what you've learned by clicking on the Earn CME Credit link. The CME post-test will follow. Please also take a moment to complete the program evaluation at the end. Thank you.